prescription drug costs. And like I said, there's separate 1,500 individuals, $2,000 family. All co-pays and co-insurance count towards that. So,
Does the mail order cost accumulate on that?
yeah, it all counts towards that. Yeah, all co-pays, co-insurance go towards that. Like right now, our mail order, that doesn't go to, it was so small, it didn't really matter, right? But yeah, they all count towards that. So one of the areas that's really become cost prohibitive is these, they call them specialty drugs, or a lot of what people refer to them as compound drugs, drugs that are new to the market or that have multiple uses. They're called specialty drugs. They're very expensive. What I always tell people, part of why our insurance is so expensive is due to the fact that we are the proving ground for all new drugs. Drug companies come to the United States to test their drugs. Once they get FDA approved, there are no caps, there are no limitations on what they can charge. Therefore, we're a proving ground for them. These specialty drugs are part of that. If the FDA approves a drug, the insurance companies have to pay it. And that's why I tell people that's part of the problem of our system versus anywhere else, is that there are no caps or other regulations on how much the drug companies can charge. Whereas with Medicare, Medicare tells the doctors and the pharmaceuticals what they'll pay, where prior to age 65, the pharmaceuticals and the doctors tell the insurance companies what they're going to pay. It's just reversed. So that's why Medicare does work in a lot of ways. But these specialty drugs is a very new, very expensive thing that's coming to the market. So if you have a specialty drug, they're part of the Specialty Guideline Management Program, and are only dispensed through the online specialty mail order pharmacy. This is not yet available as of today. They're still working on that. And these specialty drugs are typically compound drugs, and they will require prior authorization. So you won't even be able to get it unless you have the prior authorization. You need prior authorization for any brand name drug that has a generic equivalent, or will not be covered by the plan. Now, in most cases, if your doctor's already tried a generic equivalent, has not worked for you, they just do an override. They write up a letter to Caremark and explain why it doesn't work, and usually get that override. If not, we can appeal that and move forward now. But any brand name drug, yes.
If you're on the maintenance drug program right now,
Yep.
what do you have to do going forward to get on this new system? Have to do anything, mail something?
Well, you're not supposed to, but there's gonna be people who they've mapped anybody who's on an ongoing maintenance thing, right? They've mapped those. They should be seamless, especially since we're staying with Caremark. Shouldn't be an issue. There may be occasions where you don't get it. So do you do the online thing?
No.
Okay, well, I do through Caremark, you can do the online thing. It'll give you an email when it's coming and all that. I would recommend that. But what I would suggest, if you're concerned about anything coming through, just have your doctor rewrite it. Or when this one expires, just tell them, look, when this one expires, just rewrite it so that I don't have to worry about it. And then you don't have any problem with it. But it should be seamless, but nothing so far has been. So, but I would say that's what I would recommend. Okay? If you go to a network pharmacy, you are only responsible for the copay. When you go to an out-of-network pharmacy, which I don't know if there would be even any around here, you would pay the full amount and submit a claim form for reimbursement, much like we do today. So, in some rare occasions, that if your spouse has insurance for drugs, and well, that's not a rare occasion, but if you have secondary payer for the drugs, we would pick up the difference, but they're going to apply the amount we would pay as if we were the primary. Very hard to explain, but say they paid $50 towards a drug, but our plan would only pay $40 towards that drug. We're only going to pay only $40. So it's kind of complicated. Whatever, they would pay the difference if they paid it as if we were the primary. Very complicated, but it's kind of how it works today. But it's hard to explain. There are certain limitations and exclusions. Smoking cessation must be those only prescribed by a physician. Infertility drugs are limited to $5,000 per lifetime. There are certain drugs that may require step therapy, meaning you start with a generic, go to a formulary, right? Certain drugs may be limited to quantities covered. Those are usually narcotics. Narcotics are ones that would be limited to a certain amount. Certain drugs may require prior authorization. Any anti-obesity or diet pills are subject to prior authorization. Shingle shots over age 60 or age 50, if medically necessary, at participating pharmacies covered at 0% co-insurance. More on drugs. So, there are some drugs that aren't covered, obviously. Over-the-counter, experimental, investigated, or those not FDA approved. Vitamins, whether prescribed or not, now that's one of the things where we took another hit. We can't actually get some vitamins paid if it's prescribed by the doctor. We won't be able to do that going forward. Food or nutritional supplements, obviously. Refills more than a year old. Drugs prescribed for cosmetic purposes. Drugs prescribed in quantities greater than the manufacturer's recommendation. Lost or stolen. And there are others as well referenced in the book. And again, once I send that out, you'll see that these are the most important parts of that. Okay, so again, here's the sticker shock, right? This is what we end up having to deal with. So again, the 90-day supply for mail order, nobody else had that but us. We're the only ones that really had that. So everybody else got that advantage. We went from $2 to $15. I mean, quite frankly, $2 doesn't cover the cost of postage, but it is a big hit, right? I mean, it's a big change. From 5 to 30 for formulary, from 15 to 60 for brand or non-formulary. Then you have retail up to a 30-day supply. In network, we went from 10%, from $10 to 10%. Again, it seems like that could be a lot, except the difference really there is that the amount goes towards your out-of-pocket max. So that's really the significant difference. Even for $10 is probably, in most cases, going to be less than 10%, but the difference is the amount towards your out-of-pocket. Formulary is $20 or 10%, but we used to be 10%. Non-formulary or brand is $30 or 20%. Again, two 30-day supplies. Out of network, it's a big hit. You got generic, formulary, non-formulary. You're going to be liable for half the cost of those drugs if you don't go in network. And just throw the slide up here to kind of illustrate where drugs have been. If you look at the base year of 2008, at $100 being the base year, it's almost tripled in 7 years, 8 years. And by all accounts, 2016 is the highest year on record in terms of overall percentage increases on overall drugs. The amount of drugs currently used, I think generic drugs are around 65%. The formulary is about 20% of all drugs, and the rest of course, is brand names. The problem that we're seeing now, or one of the problems, there's a lot of problems, one of the problems we're seeing now is that these brand name drugs are being produced by the same company who made, the generic drugs are being made by the same company who made the brand name drug, so we're not seeing any cost advantage with that. In other words, it's not spurring a competitive advantage out there by having other companies produce the generic drug, because these same companies are producing the generic drugs, so the costs are skyrocketing. So it's a big problem. So dental. So I want to talk a little bit about this. So one of the things we talked about during negotiations, we said that Minorca and us were the only two local unions that did not have both networks for vision and dental. We agreed we would explore options because, quite frankly, when we tried to increase both vision and dental benefits, those are both very cheap benefits, really, when you look at it. So when the company says we're not adding any more liability, we try to find ways to increase the value or increase your benefit level you have. One way to do that is to try to find networks that are pretty extensive and you have access to. The example I give is a teeth cleaning, right? Currently today, if we go get our teeth cleaned using our current dental situation, it goes by 90th percentile of HIA. So if 100 dentists in this area say it costs $100 to clean your teeth, they're going to pay $90. The insurance is going to pay $90. And you're going to be subject to the other $10. Now, a lot of dentists just waive that, but that's in theory how it works. So if you go to a network situation, so that $100 comes out to $2,000 bucks, right? So you only have $1,900 bucks. So in theory, if you go to a network situation like Delta Dental or something like that, they're going to pay 85% of HIA. So that same $100, their company's only going to be on the hook for $85. So now you take $2,000, you take 85 off 2,000. Now you have more value. So you can see how that adds up over time. If you're doing it in network, your $2,000 stretches out to maybe $2,400, $2,500. you in essence got more annual maximum by finding a network that's palatable. Well, so what we did, we agreed to look at that because that's a way to expand our benefit level. The minimum threshold as defined by the international and the company was you had to have at least 2 dentists within a 20-mile radius that are accepting new patients for 95% of our members. Well, that's a pretty low threshold when you think about that. You could have 4 or 5 dentists strategically located within a certain area that would meet those requirements. That's the minimum threshold. So what I did was I started doing research back in June. I got 5 years worth of data for any dentist we've used in the last 5 years. It was just shy of 500 providers. I took every one of those, that's what I did for most of the summer, and I punched each dentist in, each provider into United Concordia, Guardian, MetLife, Blue Cross, and Delta. It took a long time, as you can imagine. So I kind of generated my own disruption report. Everybody else except Mines, Inland, and us had United Concordia. They're all from bigger regions, Philadelphia, Cleveland, Portage or whatever. And quite frankly, when they went to United Concordia, it was right out of the bankruptcy. They were happy to have anything. That's what they knew, that's what they had, right? So when I did that, I came up with 11% of the dentists in United Concordia matched up with what we had used in the last 2 years. Of the top 100, only, top 100, 11% from United Concordia mapped up. In the top 25, only 1 dentist from United Concordia mapped up with ones we had used. That, in my mind, is not sufficient. When you do MetLife, you get similar results. Guardian was about 30%. Delta PPO was about 30%, so 30 out of the top 100 or so mapped across the ones we had used. Delta Premier was closer to 70%. And of the top 25, 22 of the top 25 were people we had used before. So when you look at least the way I look at it, when you're looking at trying to change providers or networks or whatever, there's 3 things you come to mind. Plan design or benefit level, cost, and access to providers. Those are the 3 things that are important to me. So by going to a Delta Premier, plan design was the same, costs were a little bit lower, access to these